So good morning. I think we have a mayor here. Where's the mayor? Has he gone? So it was Mayor General, ladies and gentlemen, thank you very much for allowing me to come this morning. So I'm Jonathan Leach. I'm a GP now in Worcestershire. So my commitment after this is I have to go and see patients this afternoon. So I'll be rushing away after this to get back up to the West Midlands, which is where I'm based, to go and see patients. So there should be a set of slides, please. Brilliant. Thank you very much. So I'm here as the NHS England Medical Director for Military and Veterans Health, and actually perhaps just by virtue of the fact that I'm here with that title says something about the commitment of the NHS to the armed forces community. And what I'm going to do over the next sort of 20 minutes or so is to bring you up to date on a lot of the initiatives that the NHS has done, and then I'll try and focus some of those on London. But to say that we absolutely get this and the importance of the armed forces community is really, very important to say. I talk right at the top of the shop in terms of at chief executive level into the NHS and also at medical director level. So it's very important that we understand that actually that degree of input and that degree of access that we get, which of course is right. It's right because of the fact that we either are serving or have served. It's also our families. So of my 25 years in uniform, 17 were overseas. And Sue, my dear wife, trundled around, so as we did. My children were born overseas. So, it's really important that we have those links with the NHS. And then I know my colleagues will be talking about education and some of the other public services a little bit later. But they're really important. So now, with a bit of luck, if the technology works. So whilst there are sort of huge NHS England and devolved nations documents, I try and sort of chunk this down as a simple GP into two sort of things. So the first one is for those things which we have a specific responsibility for. And I'll come back to those in a second, particularly around some of the mental health services, is to make those better. And we've done a huge amount of work about those over the last sort of few years, is to make those better. But then also, and perhaps the bigger task, and perhaps the more important task, is make the NHS more responsive to the needs of the military community. And actually those two very, very simple aims is really what drives me. And just as an example, I was saying to General Chris earlier, I was talking yesterday, and I do this all the time, I met with an ex-PWRR soldier who'd got tinnitus and noise-induced hearing loss, and he'd been medically discharged out and what happened. And also met with the wife of somebody whose husband has got complex physical problems because things haven't worked the way that perhaps they would want, and certainly not the way that I would want. So I regularly do that, and I think it's really important that we show people the courtesy, also to see what we can do to try and unpick things and improve things, but also as a system we try and learn from them, and I think those are really important. And I think the other thing which is really important is that whilst I now work and am employed by NHS England and the Department of Health, actually I probably spend as much time in main building as I do in the Department of Health, and I think that's an important one. We have very good, very close relationships into the main building in particular, and also professionally with what I still call Surgeon General Department. I can't remember what their new title's called. Julie will tell me what it's now called. But anyway, if I call it Surgeon General Department, you'll know what I mean. So the current SG and I were senior medical officers in Cyprus together. So it's quite an easy ask when I need to sort of go in. So let's just give a little bit of background. And in fact, it's just sort of laying this out. There are about 2.4 million of us veterans. About half are the veterans of National Service, World War II, career generation. And then there is the younger generation, such as myself, and I suspect many in the room here. So they're quite different. And I'm going to tell you two separate stories. The first one is actually I had the privilege of serving in British Military Hospital, Hong Kong, long time ago. So at that stage, we still saw the prisoners of war from the Japanese prisoners of war camp. So they used to come into the old BMH with mental health difficulties, but also with the physical effects of the malnutrition which they suffered at the hands of the Japanese. And now in the main, there are some exceptions, that sort of group have passed. So the majority of these very, very senior, very important people, their clinical and medical needs are very similar to other very senior members of society. It's about housing adaptation, stair lifts, loneliness, depression. There is some evidence that, and we don't understand why, there's some evidence that dementia might be slightly higher in that group, but we don't really understand why. And there's lots of research going on, both in this country, King's are doing some research into this, and also in the States regarding why we might think, why that might be the case. And then the other group is the younger generation, which is really what I would describe as Northern Ireland and on. So I was in Northern Ireland 84, 85, down in Armagh, just saying to General Chris, 84, 85, as a captain. In Armagh and Bessbrook and places like that. So I have very vivid memories of a first tour, as you can imagine, straight out of medical school and our Santos and all that stuff. So, but this group is different. Firstly, they come forward earlier with regard to mental health problems. Actually, I think that's a good thing, and I'll come back to that. Secondly, their expectations of what they expect are higher. But also in terms of physical injuries, there are many who perhaps would have passed due to combat-related injuries who have survived. And that's particularly around things like the better body armour, which we used to wear. So I think many of us here will remember those plates that we used to wear, plus carrying weapons and things like this, particularly around Tellick and Herrick and places like this. So it's been better body armour, but then also the advances in medical support. So they're quite different in terms of these groups. I do have the privilege, and in fact I'm taking a group for Royal British Legion. I know they're at the back. So I'm taking another group in September who are the veterans who were there on the D-Day landings. So it's a huge privilege for me as a more recent veteran. So I'm doing their med cover, okay, as their doc. And actually, although they're all in their mid-90s, I was saying to General Chris, actually they're still 18. And I'll give you one very simple story. In the last group, and they were absolutely stunning, one chap fell over and landed on his bum, so it was really sore. So I thought, well, practical doc, let's just try and find a way where he can sit in the coach without getting too much pain. So actually, I went into Carrefour and I got him a child's rubber ring. It had Spider-Man all round it. Okay, Spider-Man. It's the only one I could get, but it had Spider-Man. Okay, they might be in their 90s, but the ribbing he got, the absolute ribbing he got from his compatriots. So that's what I mean. They might be in their 90s, but in their mind, they're 18. And actually, I think that's really important that we understand that. And the ribbing this chap got, he just took it. It was just banter. And it was brilliant. Actually, it was just brilliant. So anyway, that's a little bit of background. So one of the questions I often get, who's responsible for what bit? And this is an attempt to try and simplify some of this. So if you look at your left, I'll get my left and right's the right way around, your left, which is this side, what we've got here is for those of you who are still serving. So those of you still serving, basically the Defence Medical Services will be responsible for your GP care and also things like your psychiatry and your rehabilitation. But anything else, for example, if you need to call for GP out of hours, if you call an ambulance, if you happen to be admitted to hospital, things like actually that's an NHS responsibility and we pay for that. So just to give you a figure, in England we spend about 49 million on the secondary care, hospital care of current serving personnel, and we spend a lot of time trying to ensure that the hospital care of current serving personnel is as good as we can make it. Okay, so if you sense that, and that often comes as a surprise because people think MOD pays for the hospital care. Actually, it isn't. It's us as the NHS. Probably the most important then is the far end, which is about veterans. And then in the middle are those which reflect, for example, if you're in the reserves. They also reflect if, for example, you're overseas, if you're on ops. And again, these slides can be shared. So, and this is a rule of thumb. It's not an absolute, but it's quite a useful guide. Essentially, all the veteran side on that, your far right, get my lefts and rights the right way around, is an NHS responsibility. So much so that when, for example, if there's been something that's perhaps not gone the way as it should be, so Lieutenant General Richard Nugee, who's just stepping down as DC PERS, he contacts me rather than Surgeon General in terms of what we can do to unpick it, because it's an NHS responsibility, not a Defence Medical Services responsibility. And then I've been, one of the people I spoke with yesterday was as a consequence of that link. So essentially it's an NHS responsibility, and the bulk, if you're in England, would be the responsibility of what's called your clinical commissioning group. So that's your local NHS who would be responsible for that. But within that, there are some specific services which we've set up to specifically look at the needs of veterans. And some of those would be, for example, somebody who's unfortunately lost a limb, and the special services and funding for things like prosthetics. But also mental health, which I'll come on to. I hope that's helpful just to understand who's responsible for what, because it's commonly misunderstood. So the specific services that we've got are particularly around the mental health services. There are two at the moment. There's going to be a third. This is England. For those of you who may be sort of outside of England, there are slightly different arrangements in Scotland and Wales. And Northern Ireland has obviously got its own complexities because of the history. Although we as NHS England do support them, and Kate Davis, who's the overall director, and myself were across in Belfast just before Christmas, actually helping our Northern Ireland colleagues, because actually a lot of the clinical things are the same. For me, and I'll put it this way, and I mean, you know, I know the audience I'm in. To me, as a doctor, it doesn't matter what type of uniform somebody may or may not have been wearing or is wearing now. Okay? I need to be agnostic. What I have is a patient in front of me who has a need, who perhaps then needs a treatment. And actually that's very, very much ingrained in us as medical professionals. And essentially that was the angle we were taking in Belfast. So let's just run through some of the specific services. So set up April 2017 we went live. For London, this is the Camden and Islington Mental Health Trust, who provide what's called the Transition Intervention Liaison Service. A bit of a mouthful, but actually it describes what we do. Now, the first thing is actually this transition bit. We recognised after a lot of work that many of those with mental health difficulties could be identified prior to leaving the services. And I think that's a really, really important thing. So what we managed to get, so for those who have left, you may remember that about 2 months before you leave the military, you get a medical, normally with your doc, where you go through everything. Yeah, you twisted your ankle in Cyprus, and you did whatever else on wherever else you were. So essentially, from about 2 months out, people can be referred into this specific NHS service. You can self-refer. I'll come back to that in a second. Your GP can refer, and the psychiatrist can refer. The self-referral is absolutely fine. If you're still serving, we have to just make sure that it's safe, because if you're still serving, you still may have access to weapons. You may be working around turbines, working at height. So it's what I would describe around a safeguarding issue, really. Okay? So you can be referred into this NHS service before you leave. And the key bit here is that what we were very clear of, transition is a key part of actually making sure that people are looked after, because people were falling between. So people can be referred in. And then once people are left, again, they can be referred in. So what do you get? Well, the first thing is that we put a key performance indicator for assessment of 2 weeks. Now, that's actually very good. That's very much quicker than in terms of the NHS pathways, and in many cases, actually, the DMS, the Defence Medical Services pathways. Is there anybody here from the TIL service in London or elsewhere? Okay, so I am going to apologise to you, okay? Because I know when I speak to the TIL providers, the two-week KPI, the key performance indicator, caused problems, okay? Because that's a major challenge logistically. But clinically, I don't apologise. Absolutely not. Because what I'm trying to do is to intervene earlier. It's to intervene before people perhaps go downtown, get drunk, go on drugs, beat up the bars, get a criminal conviction. and actually spiral down. And the evidence is that if you've got people with sort of mental health difficulties, the earlier you can get involved and the earlier you can supply support, the better. So whilst I do apologise, and I've said this to Sue Ferrier, Dr. Sue Ferrier, who's your clinical lead, I've said that to her many times. Actually, clinically, I don't apologise, because it's absolutely the right thing to do. So of this now, we've had over 10,000, this is across England, so this service is right across England, so this was no small feat, as you can imagine. So we commissioned this right across England. There are 4 main providers. The bulk, actually, 30% are self-referrals. And having an open funnel, again, is deliberate. It's absolutely deliberate, because what I don't want is barriers. About 30% are by 30% are self-referrals, 25% are by our charitable partners. Actually, relatively few are by GPs, such as myself. So in the initial is that you'd get an assessment. If, for example, your needs are actually not what I would describe as medical or clinical, for example, it's housing. So London Till, for example, has very good close relationships with Stoll. It's not a military charity, it's a housing charity. Other tills, for example, up in my area, which is West Midlands, they have close links with Walking with the Wounded. So, we're using that. And then within that, there's then a therapeutic side run by psychologists who can actually help with anxiety, depression, alcohol and drug misuse and PTSD. So 10,000 through that since April 2017. And actually, I will be the first to say, and I'm sure you would say here, the numbers through have been far greater than we expected, probably about a third. So I think there's something around the numbers and something about the need. So that's the till service. And then what we also recognised very early on is that that's not enough. If I speak to some people, particularly I've spoken to many from Northern Ireland generation, from Falklands and later, where perhaps they've got long-term mental health difficulties. They have strong, what's called complex PTSD, often related to behaviours, often related to alcohol and drugs, maybe difficulties at home, difficulties in relationships. So if I take the NICE, which is the National Institute for Health and Care Excellence, so that's the body which advises the NHS on treatments. I had the huge privilege of actually being on that group when it republished its guidance just over a year ago. So that gives a total treatment sessions between 8 and 12. So when we designed this, we said, actually, that's not long enough. These are people with long-standing problems. So actually, this is the only part, it's the only part of the NHS where we've actually said, actually, as a guide, perhaps work on 32. We've actually been quite explicit about that. We've actually also funded that. So the Armed Forces community is the only place that gets that. Because the plan with this is if you've got somebody who's got some of these enduring mental health difficulties, that you need time to gain their trust. Often trust and understanding is one of the things that's in short supply. They've gone along to people in the past, been given, what they would describe as the big FO, okay? That you need to gain their trust. You need time to stabilise, time to treat, and time to reintegrate. So again, the design of this is quite deliberate in terms of looking after patients like this. And in fact, I got the police nationally saying, we want the same. We want exactly the same. They wouldn't call it the TIL, the Transition Intervention Liaison Service. They'd call it the police, the PIL, the Police Intervention Liaison Service. So actually, I've got other parts of the public sector saying, we recognise what you've done for the military community, but analogous uniform services wanting an identical. They don't have a covenant in the same way. But essentially, I think that's something about what we're doing. So the most recent data, 1,150 referrals in. That's quite a lot, Again, that's when you look at the Armed Forces community, because generally it's the younger people, it's not the older people I was describing at the beginning who would be accessing this. So again, when we look at some of these, and they get long treatment sessions for the reasons I've described. And again, it's right across England. We don't do things in halves, I tell you. And then there's this one, which we're in the process of commissioning. So what I described was, if you like, that key performance indicator was a 2 weeks. But what happens on, here we are in Lambeth. What happens tonight at 2 o'clock in the morning if somebody goes off the rails? And actually that could be somebody serving. What happens on a Saturday night in Birmingham? And whilst our crisis services are clinically very good, they're under significant pressure just because of the volumes. So what we're commissioning at the moment is what we're describing as a high-intensity service, which will go live this summer. So I won't ask my colleagues from the London till whether or not they're bidding, because actually I don't know, but this is what we're in the process of doing at the moment. And what this will consist of is what I've put here. Improved access to crisis support, and I think the key bit here is that for people who understand the military, a lot of it's language. It's about having to be able to trust. Not everybody will do it, but it's about training, particularly of mental health workers. One of the key bits is case coordination. I'm sure this lady wouldn't mind me using her husband who actually unfortunately committed suicide. But there was one case where, for example, there were 20 different organisations involved, but none of them knew what each other were doing. And actually one of the key bits in trying to prevent somebody becoming very seriously unwell is actually having much better case management, case coordination. So who's doing what? Who's responsible for what? And you have a key worker. I've done a lot of safeguarding. So for those of us who come from safeguarding, you'd often have, case conferences. So it's actually clear on who's doing what. So that case management, case coordination actually probably is the most important bit. Families. We mustn't forget the families. We've done some on families, but it's not enough. The lady I was talking with yesterday, she received a telephone call from her husband who was on top of a cliff thinking he was going to jump. She had to make a judgment about whether or not she called the police or whether or not she actually tried to persuade her husband not to jump. She called the police, and then the police didn't ring back. So she said this to me yesterday. It's absolutely true. She said, I was sat there in the car for 3 hours, not knowing whether or not actually my husband had jumped off the cliff. So we need to find a better way of supporting families. So we're trying to do that. And then the final bit would actually be for the relatively small number who actually need a bed because they're so seriously unwell. So this isn't in the same sort of rehab way as Headley Court or Stamford Hall might be. So we would use a bed for psychiatric reasons where somebody's a risk to themselves and a risk to other people. So what we want is a network of what I would describe as lead providers, designated providers, probably about 7 or 8. We would certainly look for one in London, whereby the knowledge and skills and the expertise about the care of veterans and the military community was much more embedded. And again, a lot of it is about language. It's not necessarily that what I describe as the medicine is different. So if I've got somebody for psychiatrists has got, a firefighter or a housewife or somebody who works in the bank who is at suicidal, right at the sort of mental health crisis and is suicidal. The clinical bit is the same, whether or not it's that person or a veteran. What is different is where you can actually say, okay, I've seen quite a few veterans now. They don't need to have served, but it's nice if they have. They don't need to have served. So, okay, I've seen quite a few veterans now. So you were in Telek, were you? Okay, so where did you serve? Okay, I've seen quite a few people from that. And actually it's getting that connection, it's the trust. So that actually once you've got trust, then therapeutically you can start to do things. My sort of shorthand is that the excellent psychologist that we've got up in the West Midlands, he's never served. Actually, his great uncle was in the Scots Guards. But he's now seen so many veterans, he could probably write you a map of Camp Bastion. So, do you see what I mean? It's actually about trust and knowledge. It is useful if somebody served, but it's not an absolute. It's actually having that understanding and being able to listen and being able to connect and therefore to have that trusting relationship so that if you've got the trust, then you can get onto therapy because that's the key bit. So essentially that's the high intensity service. I'm just going to run through some of the other things we're up to. So the other one is actually on physical health. And the wife I was talking to yesterday, we're going to refer her husband into this. So it's set up by Mr. Sheehan Heterachi, who's a consultant trauma surgeon at St Mary's Paddington. He's a brilliant trauma surgeon. So if you look at things like, he was one of the trauma surgeons who, he's Lieutenant Colonel in the Reserves, I must hasten to say, is that clinically he was also the one who was dealing with things like, when, the London bridge incidents and things like this. So he's extremely able, very experienced, and gets military. He will be the new chair of the Armed Forces Clinical Reference Group, which again is really good. But essentially what we're doing here is utilising the big hospitals, teaching hospitals across the country, often where you've got people who have experience and expertise of the military. So obviously there's Birmingham, which is close to me, John Radcliffe in Oxford. There's a large contingent of military medics there, Newcastle, Southampton. So what we're doing, if you've got specific problems, then people can be referred in. So we request that the GP refers into, and that's the email at the bottom, or alternative, people can refer themselves, although we would expect for a letter from the GP just so that there is if you like, a joining up of that. This is working quite well. Quite a few around pain management. We'll sometimes use the King Edward VII Hospital here in London for pain management. Lieutenant Colonel retired Dominic Aldington, who's a consultant pain specialist, works there. He's an NHS consultant pain specialist in Winchester. And again, you see the background? It's really important. It's not necessarily that medically he would be doing anything very different, but the fact that he served, the fact that he was a consultant pain clinic at Headley Court really helps in terms of helping our patients. This is really important. So I'm a GP. I was a GP when I was serving, and I'm now an NHS GP. I'm absolutely clear that getting a better response from your GPs is really important. So what we've set up, and it's not in London except in bits, but I'll come back to that, is a network now of just short of 700 practices, of veteran accredited practices. So what happens with this is that when we ask, my own surgery is one, not a surprise, we ask if you're a veteran, you code it. We've got these very sophisticated computer systems. And then you have a clinical lead. So what happens is that my colleagues know, but actually more to the point, actually my colleagues in other surgeries know that I do this. It's on our skills register for the neighbouring surgeries. So my colleagues ask me to see people, and the neighbouring ones. Actually, the most recent one, again, sometimes it's not just for the military community. My most recent military veteran was actually a veteran of the South African Air Force, who had actually seen things whilst he was serving the South African Air Force during apartheid time. He has PTSD. So actually, again, I was using, if you like, my experience as a military doctor to connect. He can't be referred into these services, but the military services, because they're for UK Armed Forces only. But in my referral letter into our mainstream services, because people can still be entitled, I can make it very, very clear. So actually, he was referred to me by one of my colleagues in the surgery. He said, "Do you want to go and see Jonathan? He's our military expert." So we've got 700 of these surgeries. Just to put that in perspective, there are 7,000 surgeries in England. Okay, so I'm about 10%. Brigadier Robin Simpson, just retired from the Army, is the clinical lead for the Royal College of GPs. And the Royal College of GPs is our key partner in this, and that's really important. So where we are with this is that it's in the Midlands, it's up in Yorkshire in the northeast, we're just going across into the northwest, and I would expect that this specifically will come to London after that. It's just a case of chunking this in terms of project management. But actually, I think this is really important. It's a really important initiative. And what I hadn't expected, I was expecting the veterans bit, but what I hadn't expected was the front end. So I've had a few patients come to me, actually register with our surgery, say, "I'm trying to get into the military, but I can't get in." And it's often around medical aspects which may or may not be in their past history. Some of those actually have been quite clear. Say, look, actually, if you're getting knee pain and you can't manage a game of rugby, it's unlikely you're going to get into the Royal Marines. Okay? On the other side, I was just saying to Julie, there was a recent chap who was trying to get in, and the screening process is set at such a high threshold that actually he was having difficulty. Actually, he said, they said, he bust his hand. He hadn't actually. I went back through his record. But then actually what I did is I saw him. I physically saw him. He's our patient. And I said, well, how much function have you got? His hands are the same as mine. He'd certainly be able to handle a weapon. So actually I wrote a letter to Capita, who's the body that does the screening, saying, this patient is fine. His function of his hand is fine. Having done literally thousands of medical boards, if I was still serving, I would grade him P2, U2, which is a normal full medical grade. So what I hadn't expected was that end, if you like, the front end of this, in actually being able to assist people to join the military who want to make that their career. And actually, it's been really satisfying to do that. And I've now done that on 3 or 4 times. I think sometimes being honest with people, like the rugby player, if you've got anterior knee pain at the front of the knee, and you can't manage a game of rugby, I'm really not convinced that the Royal Marines or 2 Para is the place for you. Yeah? So that's some of the things which I thought about. Also, in parallel, just as we got the GP accreditation, there's the Veterans Hospital or Veterans Healthcare Alliance, which is a broader network of hospitals and other trusts. It includes mental health trusts, includes ambulance services. It's often around similar things in terms of asking if somebody's a veteran, having clinical leads who know more, who can guide their colleagues and the patients regarding, whether or not there are these different referral pathways which might be available. And then the other things which probably you're unaware of. So the slow burn is that 4 years ago, my friend Robin Simpson and I got military and veterans into the curriculum for all GPs. So what that means, so if you take my daughter Helen, who is she's a qualified doctor, specialising in general practice, she will need to understand the needs of the military as she qualifies as a GP in the same way that she needs to understand about high blood pressure or twisted knees or irritable bowel or whatever. And having it in the curriculum, I think, is the biggest thing that will make a difference long term. We're the only Royal College that's done that. But I think, again, it sets a standard in terms of what we should be doing for us as the military community. And so what it means is that just before Christmas, I was in a room, a little bit smaller than this, probably from there to there, but not a dissimilar number of young doctors specialising in general practice. And I had them for an hour and a half talking about the differences and similarities between the military community and everywhere, any other patients. Now, isn't that brilliant? Tomorrow, I'm in a surgery. They've said, Jonathan, we want to know more about military and veterans health. So I'm doing a talk for their lunchtime educational talk. And I think this is really important in terms of these educational initiatives within the medical fraternity and GPs in particular. And then also there are various things on the college website regarding education, things like some of the educational, there's e-learning, things like that. And then some of the other things are just raising the profile generally, working with COBSEO, we do that regularly, John McCall, and NHS England and ourselves regularly in conversations, just as we are with the main building. Other things like mesothelioma, it's a horrid lung cancer due to asbestos. So we're very supportive of, for example, other charities. Charities are really important here. So there's one charity called Mesothelioma UK. They have specialist nurses in Portsmouth, Southampton, Plymouth, particularly looking after Royal Navy veterans. Because, again, I will defer to those who are in the senior service, but at one stage, Royal Naval vessels were asbestos from keel to decking for fire retardant purposes. So there is a concern regarding the numbers of patients that end ultimately, because it's then many, many years later. So what they're doing is supporting them. Again, the medicine is the same. So if the treatment for the lung cancer mesothelioma is the treatment, but what they can do is actually support the patients and their families and say, okay, so you were on, and again, I'm going to defer to my Royal Naval colleagues here, HMS Ark Royal in the 1960s. Okay, yes, we've seen a number of people from that. So a lot of it's around language, trust and connecting, even if the medicine is the same. Okay, but I'm very supportive of people like that, and they're doing a brilliant job. Last data I had is they've now seen 300 Royal Naval veterans. Actually, really important. And I think that's about it. So it's a real sort of huge amount of work that we've been doing as the NHS. And I hope that gives you as an insight I've slightly overrun, but I think that I hope that's useful to you in terms of understanding the vast amount of work that's going on from the NHS side to improve and make sure that the services available for the armed forces community are what they should be. And as General Chris said, it's not about advantage. It's actually not being disadvantaged. And I think that's an important message. So if you, excuse my French, buggered your knee because you were on exercise, okay, that's attributable. But if it was something, you developed a cataract or you had gallstones, I'd question why that would be attributable. So you'd be treated as a normal NHS patient. So I'm going to stop there. Where's Alex? I'd say, unfortunately, I have to go. I've got a few minutes if Alex will allow me for questions. But I have patients to see, some of which are veterans, actually, this afternoon. So I have to get back to Euston, to get back up to Birmingham, to go and see my patients this afternoon. But I hope that was useful. Have we got a couple of minutes for questions? And I apologise for going over, but I hope that was useful. Yes, sir.
So, Commander Glyn Johns. I'm a regular serving officer, 33 years in the Royal Navy, just about to leave actually. So I'm probably going to sort of call on the services of the NHS and GPs in the not too distant future because I've been so well looked after by the Royal Navy thus far. I like the idea of the GP surgeries, understanding about the military, but how do you incentivise the other 6,300 surgeries to actually take up the ownership and understand the military and contribute that extra time and effort in the ever-challenging budgets that the surgeries actually run on?
So, very fair question. So, the way we've done this is actually I'm not paying the GPs. Okay, that may be a surprise, but I'm not. So I'm using what I describe as professional levers. I reckon we'll get, by the time we pick off the other areas of the country, I reckon we'll get between 50 and 60%. That would be my aspiration. We would like 100%. The conversation I've had with my colleagues in NHS England is that would have to be contractual changes. But even then, for example, because my own surgery advertises it, it's there. So people often have choice. And all the surgeries, the names, if you go on the Royal College of GP's website, they're all there. It's all in the public domain. It's deliberately in the public domain. And in fact, there's a Google map, dotted around of where they are. So it's one of those things that as you leave the services, that may be something you would want to consider as how you then choose your surgery. Okay, it's a factor. So essentially that, but I think the broader aspects of, for example, about raising the profile generally and the fact that it's in the curriculum, that is a really key step. Okay? Otherwise I'll go. Well, thank you all very much. I hope that was helpful. And as I say, my details are with Alex. And I'm if there are any particular queries, questions, the slides can be shared. There's nothing about those. I hope you have a good rest of the day. And I say, I'll go back to being a proper doctor now, so if you'd excuse me.